Welcome everyone to the session on kidney diseases staging. This is a comprehensive guide designed for you practicing dietitians, nutrition students, and we will be covering major international guidelines that form disease kidneys management. Whether it's KDGO, KDKey, SPEN or the Indian guidelines, let us understand how we classify kidneys disease severity and tailor our nutrition care accordingly. Talking about the foundation of the kidney diseases, the kidney is a remarkable organ, and with critical jobs in the body, it filters waste, excessive water, and it also makes urine. Now, it regulates blood pressure, electrolytes, RBCs, and the kidney struggles these functional breakdowns, and that's where the kidney disease begins. Now, understanding what a healthy kidney to help us understand what goes wrong, this is essential before we can talk about it. We understand the staging and the severity. Start with how the kidneys are far more than just a filter. Okay, so the major functions, let's look at it. One is the waste removal. Two is the fluid and electrolyte balance. 3 is the blood pressure control, and 4, it is erythropoiesis and vitamin D production to stimulate red blood cells. Now, whilst we understand that the glomerular filtration rate is how we measure the kidney function, it is a clinical gold standard, and the nephron is the basic functional unit that does all the work. So you have to understand these functions that will help you understand the staging properly. Now, whilst we walk through the basic processes where we know that the glomerulus, where the kidney actually does the heavy lifting happens. So high pressure forces the water and waste molecules out of the blood, and it is like a sieve. It's like a selective sieve. The tubules, there is where the kidney gets very smart. Useful stuff like glucose, ions, water, they all get reabsorbed back into the blood, and additional waste gets secreted into the tubular fluid. The collecting duct, this is the final stage where the kidney fine tunes the concentration of the urine. It is based on the body's hydration status, controlled by hormones like the ADH. Now, kidneys don't just filter these waste. We have to remember that this is a sophisticated organ that reclaims what your body needs while it eliminates what it doesn't need. So let's look at some of the kidney related conditions. One is AKI, that is acute kidney injury. Now, this happens suddenly over hours to days. Now, think of it as a rapid drop off in the kidney function. So common triggers include severe infection, sometimes major surgeries, or even sometimes a sudden blood loss. When we talk about acute kidney disease, now this is the middle ground. So the kidneys don't bounce back quickly and the dysfunction persists. It could persist for 1 week or it could persist for 3 months. And this is that gray zone where we are waiting to see if the kidney will recover back. So when we say that chronic kidney diseases is a long game, that is progressive decline over months and years, and especially in conditions such as diabetes, high blood pressure, which are the typical culprits of these. Now, if you look at the diseases, these aren't separate silos. They don't work separately, but they are all interconnected. Someone with an AKI might develop AKD. Okay, so if somebody has developed an AKI, they could develop a AKD, and repeatedly or unresolved kidney stress can lead to CKD. So when you understand them as a continuum, that helps us recognize that the early intervention at any stage matters. So the focus here is on understanding the CKD staging, and therefore it is very essential for us to classify disease as their severity and the treatment guide their decision. Let's break down into 5 stages, and which means that how they will impact the patient management. So understanding these stages is very crucial for an intervention and slowing the disease progression. Now, in 2020, the KDIGO classified, uh, basically the classification is now for global standards for CKD staging. So the GFR categorized, which is you can see on the left, is G1 and G2. Okay, that is normal to mild disease function. Then you come to G3, which is G3A and G3B. That is mild to moderate decline, which is split into 2 stages for the better risk stratification. Then is G4, severely decreased function. And finally is G5, where the kidney failure requiring renal replacement therapy. On the right hand side, you will find the albuminuria categories, where you find it as A1, which is normal to mild increase, that is less than 30 mg per gram. A2, moderately increased, that means from 30 to 300 indicates a significant proteinuria. And lastly is the A3, which is increased severely over 300 mg per gram. And this is associated with the higher risk. So the key diagnostic requirements, that is the CKD diagnosis, requires at least 3 months of abnormal finding of GFR, albuminuria, and in some cases, structural kidney markers. Now, these ensure that we identify persistent kidney diseases, not acute changes. So, this is the dual classification system. What do you mean by dual classification system? It means one side you're looking at the GFR, but you're not only looking at the GFR, you're also looking at the albuminuria, and which provides a more nuance in the risk management than doing a GFR alone. Coming to the KDIGO risk grid. Okay, now this is a tool for assessing CKD severity and prognosis. 2 dimensions work together. That is the GFR stage G1 to G5, which you can see on the vertical axis, which measures the kidney function, and the albuminuria category, that is A1 to A3, which is on the horizontal axis, that measures the protein in the urine. So there is a color coding that tells us the risk level. So green means low risk, where G1 and G2 are normal albumin, yellow means moderate risk, and the orange means high risk. So this grid helps us to decide how aggressively you need to treat based on the zones the patient is in. So when you do a risk stratification, you move just beyond looking at the individual numbers. Okay, so this framework combines the kidney functions and the albumin levels to predict the real outcome. So when you say green, it means that a patient is in G1 or G2 with A1, that is normal to mild reduced kidney function with minimal protein losses. And these patients have a better prognosis than the others. Now, moving on to the yellow zone, that is either in the early stages with moderate protein losses, mild kidney function decline with minimal protein. So it's still measurable but requires monitoring. The other zone, which is the orange zone, so that means now we are increasing our severity. Okay, this is where is of a concern, because you could see advanced kidney disease at any protein level. So earlier stages with high protein losses, now these patients needs very close follow-up and intervention. Then you come to the red zone, that is extreme. So it's the G5. Okay, and this represents kidney failure. So at this stage, regardless of the protein levels, patients are at critical risk and need preparation for renal replacement therapy. So when we say that stratification helps us predict who will progress and who are at risk for heart diseases or who might not survive even without an intervention. So it is not just about numbers, it is the combination that tells the real story. So the Indian kidney disease guidelines, they follow the KDIGO 2020 standards, okay, but they are specified and tailored to our specific conditions and challenges. So we know India is like a hub of diabetes, hypertension, and these are the primary drivers of CKD in India. And these are the conditions we need to focus for prevention and early intervention. Now, the socio-economic realities, they shape how we actually approach CKD management here. Affordability of medications, access in the rural areas, availability of the healthcare infrastructures are the critical conditions. Now, the Indian Society of Nephrology and the international bodies do emphasize how early detection really matters, and it is very, very important. Coming to, let's take one case and just see how this 55-year-old male with type 2 diabetes and hypertension presented with CKD development. So this started with stage G2A2. That is, G2 is moderately increased risk with a GFR of 70 and a mild albuminuria of ACR of 50. The rapid decline over 2 years to stage G3B and A2, that is severely increased risk with eGFR further dropping from 70 to 40. So the eGFR dropped and there is a significant increase of the albuminuria. So the ACR is 200 here. That means the albumin ratio is, albumin to creatinine ratio is 200. And therefore, you have seen that there has been a progressive increase. Now, as a dietitian, your intervention at this stage would be to give 0.6 to 0.8 grams of proteins, minimize the kidney workload. Sometimes we even go as below as 0.55 and below that if we are giving keto analogs. Sodium potassium restriction will follow. Micronutrients also will be looked at. And this is not a talk for it, otherwise I would have gone deeper into it, whether it is iron, vitamin D, B12. These are the common deficiencies you find in patients with this stage of kidney disease. Okay, so now let us look at a little bit of AKI and acute kidney diseases. Now, when you say what is AKI or what is AKD, the importance is here when you look at the KDIGO 2026 draft guidelines. Okay, in fact, it was recently just published in just last month or so on the 31st of March for public viewing, and there is a major update since it was done in 2012. So there is now a shift of AKI and AKD, which are now recognized as a continuum rather than a separate event. So they are not two different events. They are, you have to look at them on an existing on a spectrum. Also, what this KDIGO 2026 they have said that you can look at new biomarkers which can be incorporated for the earlier detection. Of course, we know that we are looking at biomarkers of creatinine, of whether any disease condition is there, or we are looking at the different aspects of creatinine to nitrogen and the other ratios we look at. However, when you talk about biomarkers, the newer biomarkers is NGAL, KIM1, IL-18, which allow us to identify the kidney injury. Now, this is not very commonly done, but these are available as a tool to identify. The significance here is because you have to bridge the gap between acute and chronic diseases. So therefore, giving a framework of how we approach these nutritional and support them nutritionally here is an important aspect. So in the KDIGO 2012, the framework for staging acute kidney injury, the standards which were used clinically is the 3 staging system, where you have the stage 1, that is mild. When we talk specifically about the acute kidney injury, that is AKI, in stage 1, which is mild, the creatinine rises to 0.3 mg per deciliter within 48 hours, and or it increases to 1.5 times the baseline within a week, and the urine output drops. So it is both increase of the creatinine okay, as well as dropping of the urine output below 0.5 ml per kg per hour for at least 6 hours. So first you look at zero point 0.3 for 48 hours. Then you also look at dropping of the urine output. So this is mild. If you want to understand it further, and we'll say it is now moderate. How will you identify it as moderate? So when the creatinine increases more than 2 times, between 2 and 3 times from the baseline. So whatever is a baseline creatinine, above that, if the creatinine doubles or it increases 3 times, and at the same time the urine output also decreases, okay, 0.5 ml per kg for hour, and for at least 12 hours. In the previous staging it was 6 hours, and here it is stage 2, it is 12 hours. In stage 3, that is severity. So creatinine more than 3 times the baseline, and it reaches 0.4 mg per deciliter, or the patient has already started on a kidney replacement therapy, and the urine output is below 0.3 ml per kg per hour for 24 hours, or a complete anuria for 12 hours. So you need only one criteria to be met. Either the creatinine changes or the urine output changes. And to this stage of AKI, we don't wait for both to monitor the activity thoroughly for the patient's course. So even if one is positive out of these, it is said to be an AKI based on these stages. So AKI staging follows 3 progressions from stage 1 to stage 3. Initial detection phase representing the lab testing, 2 the warning signs that emerge requiring heightened attention, and 3 is when there is a critical deterioration. Okay, remember one thing, the staging is not static. Patient can move in either directions. Either they improve and recover to an earlier stage, okay, or from that stage they can worsen or progress to a more severe stage. Now, nutritional intervention hence also must be dynamic based on the responsiveness and the staging system. So reassess, adjust the nutrition support at each stage transition. Don't set a plan and forget about it. The patient has to be adapted based on the clinical staging. So each stage transition is an opportunity for you as a dietitian to monitor and to modify the nutritional approaches. Now coming to the novel biomarkers. I know this is a little new, but in 2026, as per the KDIGO draft, they did say that you can use NGAL, KIM1 and IL-18, which can detect an AKI even before the traditional creatinine level rises. This early detection window is crucial for intervention. It is not widely spread, but it is available. And I think going ahead, maybe, physicians and clinicians may adapt using these markers. Risk prediction tool, that is validation of the scoring systems, are now available to identify which patients are at a highest risk for developing AKI and allowing for more targeted monitoring and prevention. So when we talk about this continuum, that is AKI to AKD, this framework they connect the 3 stages. Which are the 3 stages? That is the acute kidney injury itself, the acute kidney diseases, okay, and its progression to chronic kidney diseases. So understanding this continuum helps us see that AKI is not an isolated event, but it is a potential starting point for a very long-term kidney problem, and hence nothing needs to be ignored. When we say how do you define an AKD very clearly, it is not just the acute kidney injury itself, but it is the whole recovery period, including any lingering damages that even last up to 90 days after the initial event. Okay, so emphasizing the critical window here, the AKD sits between AKI and CKD. Okay, which means that when we can actually make a difference and prevent a long-term complication, that is at the AKD stage. Your role as a dietitian and a nutritionist is to support during this recovery phase, and this is key in helping the patients avoid any progression to from AKD to CKD. So we need to keep monitoring the EGFR, the albumin levels, the urine output, and even after the patient leaves the hospital, you have to tell the patient whenever you're doing your test or you have some doubts, you need to get back to catch the problem early, and then you can adjust the nutrition plan according to the needs. It could be adjusting for phosphorus, it could be adjusting for sodium, adjusting for potassium, adjusting for proteins. And that is why you are the person who should be connecting the dots. And this is not about managing an acute event. It is you are the ones who will prevent the lifetime chronic disease problem through your smart intervention during the recovery phase. Now, in the Indian guidelines, which is also aligned to the KD Go 2012 standards with 2026 updates current review, that is these biomarkers which I just spoke about, NGAL, they weren't widely available outside, and it's very difficult to find it even in smaller cities as well as in bigger cities. However, for Indian practices, dehydration related AKI, infection related AKI, drug induced injuries, and these are the most common problems which can be easily, the burden can be reduced. People should be educated for NSAID uses or using of herbal nephrotoxins, obstetric emergencies. Basically, these disease patterns and healthcare context specified to India when it is very different from the Western countries. Let's look at a quick case, which a 70-year-old female, severe sepsis, experiencing rapid kidney function decline over 5 days. At baseline, her normal serum creatinine is 1 mg per deciliter, adequate urine output, and there is no signs of AKI yet. Now on day 3, what happens? Her creatinine doubles from 1 to 2.5 and the urine output drops to 300 ml in 24 hours. So now if you look at what stage she meets the AKI stage 2 criteria. Okay. If she further deteriorates, her creatinine will again jump up. Okay. So, you hear of people saying, the creatinine was just jumping. And that's when the creatinine now jumps to 3.8 mg per deciliter. And there is even further reduction of the urine output to 150 ml in 24 hours. So now she has quickly reached to the stage 3. So as a dietitian, your focus is to also shift the kidney function decline. Here, you have to carefully look at the fluid balance. You have to look at the electrolyte balance. You have to provide sufficient amount of energy, 25 to 35 kilocalories. And if the same woman has to undergo a kidney replacement therapy, KRT, which is initiated, then you have to obviously increase the proteins from 1 to 1.2 on account of the losses and to prevent the accumulation. So this is how the quickly the AKI can develop in a septic patients, and why you need to keep on changing your diet plan accordingly. Now the focus is on nutritional management. Here you have to understand various stages of kidney disease and how you can very quickly, I will run through how you can nutritionally manage this, because today is a class of staging only. We will do nutritional management in another class. However, just to understand staging, I thought let me give you a little idea of how it will happen. So as we know, nutrition is one of the most powerful tools that you have in managing a CKD patient or any kidney disease for that matter. Okay, so a well designed renal program where diet is looked at, and you have to manage the complications through nutrition. Whether you are looking at cardiovascular protection, whether you're looking at the quality of life of this patient, but these are all the pillars that you need to work around so that you are able to give the right justice to the patient. According to the KDCO 2020, the key nutritional recommendation is protein intake if it's a non-dialysis CKD and the patient requires even 0.5 to 0.8 grams of proteins per kg body weight. Here also it depends upon how much of high biological value you are providing. So it should be at least 50% of high biological value proteins. And if the patient starts dialysis, whether the hemodialysis or peritoneal dialysis, protein needs to increase accordingly. So 1 to 1.2 per gram per kg ideal body weight, and energy also needs to increase accordingly. So your assessment will start here. Use your biomarkers, take a look at the albumin, take a look at the creatinine, the BUN, and then you do your assessment accordingly. Check for iron, vitamin D, and other vitamins as well. In ESPEN 2021 guidelines, ESPEN, for clinical nutrition with acute or chronic kidney patients, there are three key takeaways. So when the patient is on enteral nutrition, you have to be very, very careful, especially prevent protein energy wasting. Look at the electrolytes here of this patient, and you can create a good diet for this patient. Even monitor very closely the sodium, the potassium, the proteins. You give foods that are friendly to these to the CKD stages. Protein targets will be low if you are dealing with the patient based on the staging. Now, here you have to look at the overall, not only the protein, but at the other nutrients as well: sodium, potassium, phosphorus, fluid. All these are required. So these are some of the nutritional strategies which you can, go ahead for dialysis patients. Again, today is not a class for this, so I'm not taking it this into detail, but I just thought I will flash one slide with regards to this. Also, with nutrition support during AKD and AKI, that is non-dialysis, you start with a low protein, zero point 0.8. Sometimes you, based on the patient's need and the severity of the disease and the malnutrition status, you can go up to 1 gram as well. But if this patient, even in an AKI, is on dialysis, you need to give higher proteins. So 1 to 1.2 grams is required. At the same time, remember, do not compromise on the total energy that you are giving to the patient. These are the different nutritional needs across the staging. So in early stages, where there is CKD 1 to 3, you can give a low protein diet. You can start with 0.6 and increase to 0.8. If the patient is here on keto analogs, then you can give up to 0.3 to 0.4 grams of proteins as well. However, if the patient is not on keto analogs, then you need to give a little high biological value proteins, where you give at least 50% of the first class protein. Even if you want to reduce it to 0.5, you need to see to it that your quality of proteins is taken care of, because here it is important that the patient is able to have a high quality proteins in order to prevent sarcopenia. Okay, now in the practical aspects, what as a dietitian you can do a dietary assessment, anthropometric assessment, look at the biochemical parameters, and accordingly also educate the patient. Use local foods as much as possible. You bridge the gap, start with easy solutions that are easily available in local markets. Do not go in for a very high end or high funda foods, which patients get more confused. So you explain to them how they can fetch locally. Again, looking at a small little case, 60-year-old female, stage 4 CKD, presenting with fatigue, poor appetite, and inadequate protein intake. If you counted her protein, she take 0.5 grams of proteins, and energy also was not too much. So what will the dietitian do now? First of all, the dietitian will increase her energy intake, okay, so that she is getting enough of calories. And now if she is not able to eat, here is where you can introduce an ONS which is friendly to her renal system. You closely monitor her for a few days, whether it is for potassium, phosphorus, okay. And over the 3 months here, you need to monitor her closely, so that you have to see whether she's showing any improvement in her energy levels. Is her GFR getting stable, or is it remaining steady, or it is deteriorating? These are some of the newer tests, whether it is NGAL or it is the KIM, the IL, these are all newer tests which have been reported in the KDICO 26 guidelines. So, coming to the early morning signs, now creatinine delayed rise means we are often playing catch up, and at the time there is a signaling. We have to understand that these are opportunities where we can work fast and work quickly so that the patient does not progress into the next stage. Yeah, these are some of the ways where as a dietitian you can basically look at technology to integrate. You can look at gut microbiome, you can look at personalization. Yeah, these are some of the final takeaways so that you understand, because here today we have a lot of students as well. I will be just explaining little key concepts to them. So when you start with the EGFR and albumin to creatinine ratio, that is the ACR, to classify the CKD using the KDIGO stages. So stratify for and use accordingly so that you are able to do it correctly. Also, when you're talking about the walkthrough, let me walk through the stages just for students to understand a little better. So G5 is kidney failure, that is eGFR is less than 15. G4 is severely decreased function where the eGFR is 15 to 29. Now stage 3 is divided into two, G3A and G3B, and it is moderately decreased, that is 30 to 59. G1 and G2 are normal to mild decrease where it is 60 and above. Also, you need to look at the albumin categories right from A1, where there is normal to mild increase, that is 30 mg per gram. A2 is moderate and A3 is severe. This is just for a sum up of what we did in the first slide. And just a recap of what the stagings are, whether it is stage 1 of AKI, creatinine rises by 0.3, reaches 1.5 time baseline. Urine output drops from 0.5 for 6 hours. In stage 2, creatinine reaches 2 to 3 times more the baseline. Urine output stays low for 12 hours. Stage 3, more severe, creatinine becomes 3 times or more than the baseline, above 4, complete anuria for 12 hours, or the patient is already on some CKD, renal replacement. So AKD is the focus, and this is when the kidney dysfunction persists for a week to 3 months after the initial injury. Now think of this AKD as a bridge between the acute kidney injury and chronic kidney diseases. And when you look at it in a continuum, you will be able to treat this nutritionally properly. So it will help you to track how your recovery can happen and how your nutrition can also progress. So nutrition professions are important here, because as you detect the earlier nutritional intervention you'll be able to do, and it will help the disease from progressing into CKD. And a lot depends upon your collaboration with the multidisciplinary team, whether you're working closely with doctors, nephrologists, or a community health worker. It is important, your role here is important. Okay, so the team approach is definitely important, and what you can do is use newest technology as much as possible, which can help you to prevent the progression of the diseases. Also, prevent, slow, and improve is what you want to look at, a collaborative vision for a future renal function. Okay, if you get a chance, just go through some of the key resources, whether it is the KDIGO guidelines, the KD key guidelines, that is National Kidney Foundation, the SPEN guidelines. Even the Indian Society of Nephrology has some very good regional resources for the Indian practitioners to encourage you. Please go on these, take a look at it and read a little more. It really makes sense. Then comes to your the other guidelines, which is very easily found. You can use these links which I have provided to learn more about the newer updates. These are some of the SPEN guidelines which are available on the site. Coming to the Indian Renal Association, or whether it is the Indian CKD in the Indian CKD context, Indian Society of Nephrology. So these are some of the key terms. For the sake of the students, I have put it down so that you can understand what a GFR actually means. What is the definition of the GFR? The students can probably even screenshot this. What a glomerular filtration rate is, what it means, what are the terms, what is eGFR, that is the estimated glomerular filtration rate. Again, students should understand what albuminuria is, what is normal, moderate, and severe. The albumin to creatinine ratio, yeah, this is the sample formula where you can understand this. Acute kidney injury, full form. This is the definition as per the KDCO. Again, the acute kidney injury, as I said, is a continuum. You look at the bridge that it is showing, it is the AKI, the AKD, and the CKD bridge. Okay, chronic kidney diseases. There are structural markers, functional markers, and the causes most commonly available in India. Okay, so the KDCO is basically kidney disease improving global outcomes, and these are some of the sites which is easily accessible when you go onto the internet. And thank you for listening to me, and it's really a pleasure to talk to you so much. And if you're still keen on understanding more on how to plan kidney diseases and kidney disease diets in various stages, whether it is AKI, AKD, or CKD stages, I will be most happy to help you all and give you all a class on uh, planning nutrition for patients on different stages of kidney diseases. So it is not one size fits all. It is individualized based on what you are reading as reports. We can do an entire class on report reading. We can do an entire class of how you prescribe phosphorus, potassium, protein, sodium, anything. It's like long classes, but do ping me and let me know if you need much of it. In the meanwhile, take care and thank you very much.